Venkatesh, who's the Chief Medical Officer of Glaucoma Services at Arvind Eye Care Systems, and he's going to talk on steroid-induced glaucoma. On to you, Doctor.
I take this opportunity to thank Dr. Chitra Madam for conducting a series of excellent webinars. So let's see this young boy with the VKC who was on and off steroids for 3 years, good vision, but raised intraocular pressure. So we had to start on anti-glaucoma medications. It didn't get good control, so we had to do both eye trabeclectomy. This is not one patient. We see several patients having steroid-induced glaucoma. So the concept is why this topic? Ophthalmic steroids are easily available over the counter. And many of the times they are diagnosed in a very advanced stage because people don't realize the seriousness of steroids. So who is a steroid responder? The older definitions have gone. Now the most widely accepted definition is if you have an IOP increase of more than 10 over baseline with also some clinical significance. When we talk about the classification, like the epidemiology, after 4 to 6 weeks of topical DEXA or betamethasone administration, the non-responders who have less than 5 are almost 60%. The moderate responders have 6 to 15 intraocular pressure, or roughly 30 to 35%. And the high responders are roughly 5%. These are the people we have to keep a watch. Sometimes, some higher percentage of normal individuals can have raised IOP if they are using a greater frequency of steroids, higher doses, and also for a longer period. So definitely genetic susceptibility is a risk factor, age, very old or very young patients, previous glaucoma diagnosis, first degree relatives of open angle patients, connective tissue disease, high myopia, and also angle recession glaucoma are risk factors for steroid-induced glaucoma. This is a study we did some time back in our general units where we see 18 to 40 years of age, 28,000 patients were screened, of which 296 were referred to glaucoma clinic, 84 with raised intraocular pressure. And if you see steroid responders are in a bigger group in this particular group. So I'm not going to get into the details of pathophysiology, but the most widely accepted theory is that corticosteroids increase the accumulation of extracellular matrix. They also stabilize the lysosomal membrane and also increase the water binding capacity of mucopolysaccharides. As a result, what happens is there is narrowing of trabecular beams and decrease in the aqueous humor outflow, which elevates the intraocular pressure. There are several routes, but the ocular route is the most notorious to raise the intraocular pressure. So topical steroids normally at 4 to 6 weeks, they raise intraocular pressure. And if you stop at 6 weeks, within 2 weeks, that is within the 8th week, it should return to normal. So if the trabecular meshwork changes are reversible, IOP returns to normal in 2 weeks. If it is irreversible, then the IOP raise may persist up to 18 months. And there is a subset of people who can have an acute raise within a week, 10 days. We have to really watch these patients. If you see the genesis of steroids, now in 50s and 60s, we had prednisolone, dexamethasone, betamethasone, and then we had fluoromethanol in 70s. Late 90s, we had lotoprednol, and in 2000, we had difluprednate. So this is a meta-analysis which clearly shows you how dexamethasone, prednisolone, and few other steroids, the range of IOP increase is somewhere between 9 to 22, and there is a significant number who have this response. And this is after an application of somewhere from 3 to 12 weeks. And if you see the less potent steroids, difluprednate and lotoprednol, does not significantly increase the intraocular pressure. The other important is intravitreal steroids. We have triamcinolone, fluocinolone, and dexamethasone. And the risk of raised IOP is more with fluocinolone followed by triamcinolone and then dexamethasone, which is biodegradable. So when you are giving intravitreal steroids for definitely people with glaucoma suspects or glaucoma, if they have pre-existing uncontrolled glaucoma, then we have to reconsider. If there are patients with IOP greater than 21 on treatment and they have slightly higher intraocular pressure, then we have to very closely monitor them by visual field testing, imaging, and also, after injections, we have to closely follow them up. If they have a good control of intraocular pressure, maybe suspects of mild glaucoma, then you just monitor the intraocular pressure. So let's say that they are on topical steroids, you want to continue the topical steroids. So you try to use lower concentration, you use weaker steroids, and then you also closely monitor their intraocular pressure, or even give anti-glaucoma medication and then follow them up. So this is one work done by our resident. This is again to change practice. Do we really need steroids following an YAG iridotomy? So that was the question. So we compared, we randomized nepafenac versus prednisolone acetate. And we found that there was a greater increase of IOP with prednisolone group as expected. More than that, nepafenac was non-inferior. That means it was equally good. And the other important thing is the rebound iritis happened more with steroids than in the non-steroidal group. So now our practice has changed to non-steroidal in an iridotomy, and it has changed the practice pattern across Aravind. Finally, you can manage steroid-induced glaucoma like similar to open angle. Only thing, you have to reserve prostaglandin analogs in cases with uveitis. SLT can buy time in some cases, especially where you have given intravitreal triamcinolone. And when it comes to surgery, anything again in open angle, trabeculectomy and non-penetrating deep sclerectomy works well. And if it fails, shunt procedures, and that also fails cyclodestructive procedures. Sometimes you may have to remove the repository steroid. Now in intractable glaucoma, that's an option. You remove those steroid, and at the same time, you can combine a glaucoma surgery. And also the newer procedures in the form of minimally invasive glaucoma surgery can also work in some of these patients. Thank you.
Thank you very much for a wonderfully detailed talk and a lot of information which came through. I have a question here for Dr. Vijaya. How safe are the softer steroids and why?
In the sense, how safe are topical steroids?
Yeah, which one of them?
No, see, I always tell that steroids are essential. There is no doubt about it. If it's needed, it's needed. And susceptibility to steroids in the form of raised intraocular pressure, we have to manage looking at the risk versus the benefits. The problem with the steroid-induced glaucoma, at least in our country, is that misuse of the steroids leading to glaucoma and the blindness. In clinic, which happens the raised pressure, almost 100% of the times, it is taken care and it is reversed. So the cases what we see in our clinics are mainly children and young people who keep using the steroid drops forever because they would have been prescribed for some kind of allergy. So indiscriminate use of steroids are the problem for us. So I don't stop anybody to use the steroids if it is needed for the medical reasons for treatment, like bad uveitis or any other lesion that requires topical steroids. Yes, please go ahead and use the steroids. We monitor the pressures and manage the glaucoma. That's my view as far as the steroid-induced glaucoma is concerned.
What I understand about soft steroids is that if you use a lotipred, the incidence of steroid-induced glaucoma is something just about 4%.
No, if somebody is responding to steroids, even with the FML, the pressure will go up. Even with the skin ointment, I think Venkatesh, maybe time was not enough. Majority of the times what we see in our clinics, the exaggerated steroid response are people with the asthmatics, who are on the long-term inhalers, and people on the skin lesions. They are notorious because the skin lesion is an exposed lesion. When they apply the steroid ointment, it gets into the systemic circulation. So these are all the real villains for steroid-induced glaucoma, rather than just a topical steroid which is used for a purpose.
No, I agree on that. But compared to Predfort, lotipred incidence of steroid-induced glaucoma.
Yes, definitely. But if the Predfort is needed for the management of the eye condition, I won't hesitate to continue with the Predfort.
In this continuation, diflupred has been commonly used by many retina specialists. What is its side effects? What you people face, ma'am?
We would use it even if the IOPs are very low in the early post-operative period. Even I use it, but I think we would be careful. We'll have to titrate IOP because sometimes in these eyes, IOP goes up rapidly. I mean, I stand to be corrected. What is the experience of others? If there is hypotony in the immediate post-op period, I'm sure some of us do use diflupredate.
Can I just add something?
Yes.
So I think that the steroid-induced glaucomas will continue to bother us still for a very long time to come. But one important thing that I'd just like to point out is that there's a very high risk of developing glaucoma even with just a little bit higher increase in axial length. That is, myopia is a very big risk factor. And all patients, one should consider that all patients of myopia, be it mild myopia or moderate or high myopia, one should consider that they are all steroid response unless proved otherwise, actually, which means that if you operate on a myopic patient, let's say someone has an axial length of 25 or 26 millimeters, and you operate on them and give them post-operative steroids, and that's quite justified because you've done a cataract surgery. But please watch out for an elevation of intraocular pressure. So I think that's very, very important that when we have a myop in front of us, we do everything to assess the intraocular pressure if we give steroids.
True. Does GAT have a role in this steroid patients with steroid IOP is very high and you want to do some surgery? Dr. Shushmita? No, she's not there.
Ma'am, unmute, please.
Yeah, sorry.
Yeah.
Yeah, so a lot of them would be reversible once the steroid is stopped. So
Yeah.
surgery would not be the first.
True.
We would consider surgery only if there is persistent raised pressure and there's optic neuropathy despite discontinuation of steroid. And yes, GAT would, I think, logically work because the outflow channels are okay. And if you remove trabecular meshwork, but maybe you could do something short of a 360 degrees as was being told. But a lot of them, by the time they require surgery, again, the problem is that, it's 40 pressures, it's a total cup. And in a condition like that, I would not be wanting to do minimally. Just one point about the so-called softer steroids. I think the thing is that they don't penetrate. And because they don't penetrate, they don't raise the pressure so much, but they also don't work as well. So
But
if you really want,
breached, then all of them are on the same boat, I think.
Yes. So intraocular inflammation do not respond to lotepred or FML, and therefore the steroid responsiveness would not be there. So if you require it for intraocular, you require something that goes in, and then the steroid response is higher.
Thank you.